Usually when we talk about a medical diagnosis, there is this expectation of precision.
Right, like structural engineering or something.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points at the film and says, well, there it is.
It is binary. The bone is broken or it is not. The image is clean and the path forward is obvious.
And it is comforting. We like things to be visible, to be perfectly categorized.
Oh, absolutely.
But then you step into the world of the human heart, specifically repairing the human heart. And suddenly that simple, clean diagnostic landscape just vanishes.
It is completely gone.
Right. We are looking at a space that is the absolute definition of diagnostic muddy waters. And right now, there are millions of artificial heart valves beating inside people's chests.
Millions.
Yeah. And if one of those valves starts failing, doctors can't just casually open the patient's chest up to take a look. They have to play this high-stakes detective game from the outside, trying to peer into a constantly moving organ.
And, the scale of this challenge has grown exponentially.
Because of the new surgical methods, right?
Exactly. Over the last 15 years, transcatheter implantation techniques have become completely routine.
That is where they don't even open the chest.
Right. We are routinely threading new heart valves up through a patient's blood vessels and deploying them without ever cracking the chest open.
Which is incredible.
It is. But because of that incredible success, we now have millions of these devices operating in the wild. And monitoring those artificial valves as the years go by and figuring out exactly why one might be struggling, well, it is one of the most complex imaging puzzles in modern medicine.
Okay, let's unpack this. Today, our deep dive is centered on an incredibly detailed, multi-society consensus document on using cardiac computed tomography, cardiac CT, to assess prosthetic heart valve.
It is a massive document.
It really is. And whether you are a medical student, an engineer, or just someone who is insanely curious about the human body, understanding how we replace and monitor the doors of the heart, basically, is going to change how you look at medical technology.
Oh, definitely.
We are going to look at how doctors use cutting-edge imaging to physically freeze a beating heart in time, just to catch microscopic failures.
But before we can appreciate the ultimate diagnostic camera, which is the CT scanner, we have to understand the hardware we are actually trying to photograph.
Right. What is actually inside the patient?
Exactly. When a patient needs a new valve, they are generally receiving one of two entirely different engineering profiles, a mechanical valve or a biological valve.
Let's start with the mechanical ones.
So mechanical valves are man-made machines. Today, they typically feature bi-leaflet designs.
Bi-leaflet meaning two little doors.
Yeah, two semilinear carbon discs suspended in a metal ring. And they swing open and close with every single heartbeat.
Wow.
Though, depending on the patient's surgical history, you might still encounter older designs like tilting discs or even vintage ball and cage valves.
We have ball and cage.
Yeah, they literally feature a small ball bouncing up and down inside a tiny metal cage to regulate blood flow.
That sounds like a pinball machine inside your heart.
It kind of is. But the trade-off with those mechanical valves is fascinating. Because they are made of pyrolytic carbon and titanium, they essentially don't wear out. They can last a lifetime.
But there is always a catch in medicine.
Always. The human body's coagulation cascade is highly reactive. Your blood recognizes that metal as a foreign surface, and its immediate biological response is to clot around it.
So they have to take meds for that.
Right. If you have a mechanical valve, you are on lifetime anticoagulation. Heavy blood thinners just to keep those carbon doors from gumming up.
And the biological valves bypass that specific problem, right?
They do. These are made of organic tissue, most commonly bovine or porcine tissue.
Meaning cow pericardium or PICC valves.
Exactly. This tissue is specially treated and then mounted on expandable metal frames.
Okay, so it is biological tissue on a metal skeleton.
Right. And because they behave much more like your natural organic tissue, the blood flows over them smoothly. Patients often only need a daily aspirin rather than severe blood thinners.
But the trade-off reverses here, doesn't it?
It does. Just like your natural joints, biological valves undergo physical wear and tear. Over a decade or so, they can calcify, stiffen, and eventually fail.
So we have these complex metallic and biological machines constantly opening and closing under the immense pressure of the circulatory system.
Yeah.
When doctors need to check on them, the absolute first-line tool is echocardiography, an echo.
Which is essentially an ultrasound of the heart.
Right. It is a great starting point because it doesn't use any radiation, And the Doppler features can perfectly measure the speed and direction of the blood flow.
It is very safe and effective.
But an echo has a massive physical blind spot when it comes to artificial valves. Think of it like an acoustic shadow.
I like that term.
Yeah, imagine you are trying to take a photograph of your friend, but your friend is standing directly in front of a blinding million-watt stadium spotlight.
You wouldn't see anything.
Exactly. The glare just washes everything out. You can't see their face, their clothes, nothing. And that is exactly what ultrasound waves do when they hit metal.
Right. The sound waves from the ultrasound transducer hit the dense metal struts, the titanium housings, and the thick sewing rings of these artificial valves. And they just cannot penetrate the material.
They just bounce off.
The sound waves bounce right back to the probe. This casts literal shadows on the resulting image, completely masking any anatomical structures located directly behind the metal.
So it is just a dark void on the screen.
Exactly. If there's a tiny, dangerous blood clot or a pocket of infection hiding on the far side of that metal ring, the echocardiogram simply cannot see it. The diagnostic picture is blinded by that acoustic shadow.
I am stuck on the physics of the solution here, though.
Yeah.
If ultrasound hits a brick wall with these metal shadows, the consensus document says doctors pivot to cardiac CT.
Yes, they do.
But a CT scanner takes time to rotate its X-ray tube around a patient's body, right? The human heart is beating 60 to 80 times a minute, and these tiny valve leaflets are snapping shut in fractions of a second.
It is a very fast, violent motion.
So shouldn't the resulting CT image just be a massive, blurry smear? How are they getting a sharp 3D picture of a target that is constantly moving?
What's fascinating here is the sheer computing power required to pull this off. They're performing what is called 4D CT imaging.
4D.
Yeah, capturing 3D spatial resolution plus the fourth dimension of time. To freeze that motion, they use retrospective ECG-gated image acquisitions.
Okay, that is a lot of syllables. What does that actually mean?
Basically, the CT scanner is directly wired to the patient's electrocardiogram. It is continuously listening to the heart's electrical rhythm.
Oh, so it knows exactly when the heart is beating.
Right. The scanner doesn't just try to snip one fast photo. It acquires a continuous stream of overlapping image data across multiple heartbeats, capturing slices at 5 to 10% intervals of the entire cardiac cycle.
So it is recording everything all the time through the whole beat.
Precisely. Then the computer algorithm looks at all that raw data, references the electrical ECG spikes, and essentially discards the moving frames.
Just throws them out.
Yeah. It selectively pulls out the microscopic slices from the exact same millisecond of the resting phase across dozens of different heartbeats. Wow. And then it stitches those perfectly matching slices together to build a high-resolution 3D model of the heart perfectly frozen in mid-beat.
It is like taking a long video of a hummingbird's wings, picking out the single frame from 50 different wing flaps where the wing is in the exact same position, and layering them to make one perfectly sharp image.
That is exactly it.
But that only solves the motion problem. To punch through that stadium spotlight glare of the metal, the source material details some really intense physics.
Oh, the physics are wild.
They crank up the X-ray tube voltages to 140 kA.
Right, kilovolt peak.
X-rays are basically packets of photon energy. By cranking the voltage that high, they are giving those X-ray beams enough sheer physical energy to literally pass right through the dense metal of the artificial valve rather than scattering off it.
It is brute force, honestly.
Yeah. And they combine that with dual energy, monoenergetic image reconstructions, and iterative metal artifact reduction software, basically digitally scrubbing away whatever glare is left.
And on top of the physics and the software, the clinical protocol demands a highly specific recipe for the contrast dye they inject into the patient's arm to make the blood light up.
Oh, right. The timing has to be perfect.
Very perfect. For left-sided heart valves, they use a triphasic injection protocol.
Triphasic meaning 3 steps.
Exactly. It starts with a bolus of pure contrast dye, follows with a mixture of saline and contrast, and finishes with a chaser of pure saline.
Why not just pump the dye in all at once?
Because if the entire heart is glowing brilliantly with contrast, the visual noise is overwhelming. You wouldn't see the valve properly.
It would just be a glowing blob.
Right. This specific timing ensures that the contrast dye washes completely out of the right side of the heart, leaving it dark, while the left side, where the target valve is located, lights up brilliantly against a clean background.
So we have beaten the acoustic shadows, we have frozen the heart in time, and we have a flawless 3D picture of this artificial valve.
We have the perfect map.
Right. So the first major category of valve failure doctors look for on these scans is an obstruction, something physically blocking the door.
Yes.
And the precision of the CT scan is wild here. The manufacturer of a mechanical valve specifies exactly how many degrees those carbon leaflets should swing open.
Down to the degree.
Down to the degree. If the CT scan measures the leaflet angle and finds it deviates more than just 4 degrees from the factory specs, the valve is flagged as obstructed.
And when that happens, doctors are hunting for one of two culprits, thrombus or pannus.
Here's where it gets really interesting, because those two things are vastly different.
They are. Identifying which of those two is causing the obstruction is one of the most critical decisions in cardiology.
Let's break them down.
So a thrombus is a blood clot. Biologically, it happens when blood flow stagnates or the anticoagulation medication isn't dosed perfectly.
And that allows red blood cells and platelets to clump onto the hinges.
Exactly. On a CT scan, a thrombus shows up as a low-density, irregular, lumpy mass attached to the valve.
I like to picture this using a home plumbing analogy.
Go for it.
A thrombus is like a nasty hair clog in your bathroom drain. It is physically blocking the flow of water, yes, but because of what it is made of, you can often pour a harsh chemical liquid down the drain to dissolve it.
That is a great comparison.
Right. Medically, that translates to treating the patient with heavy blood thinners or aggressive thrombolytic drugs to literally melt the clot away without ever opening the chest.
But pannus is an entirely different biological beast.
What is it exactly?
Pannus is an overgrowth of aggressive scar tissue.
Yeah.
It is the heart's own tissue essentially rebelling against the foreign metal.
It fights back.
Yeah, the heart tries to heal over the implant by sending a creeping vine of myofibroblasts and dense collagen to slowly swallow the valve ring.
Wow, that is terrifying.
And on the CT scan, pannus has a very high attenuation, meaning it is physically much denser than a blood clot, typically measuring over 145 Hounsfield units.
Hounsfield units being the scale used to measure density on a CT.
Exactly.
So going back to the plumbing, pannus is not a hair clog. Pannus is what happens when thick tree roots have grown right through your underground pipes.
Yes, perfect analogy.
No amount of liquid chemical drain cleaner is going to dissolve a tree root. You have no choice but to bring in a backhoe and dig up the yard.
Medically, digging up the yard translates to a high-risk redo open-heart surgery to physically cut that dense scar tissue out and replace the entire valve.
Ouch.
Yeah, and this highlights why getting this diagnostic distinction right is a matter of life and death. If a doctor misdiagnoses a simple thrombus clot as pannus, they're sending a patient into a highly dangerous, unnecessary open-heart surgery.
Which you never want to do.
Never. But if they misdiagnose pannus as a thrombus, they will pump that patient full of dangerous hemorrhage-inducing blood thinners that will do absolutely nothing to clear the structural scar tissue permanently blocking their heart.
So the CT has to be right.
And it is vastly superior at making this call. The data shows CT has an 85% sensitivity for diagnosing pannus compared to only 62% using a transesophageal echo. The X-rays just see the tissue density so much clearer.
Okay, so we have solved for physical blockages, like clots and scar tissue. But CT scans aren't just looking for what is blocking the valve. They are looking for what is actively destroying it from the outside in.
Right, the invaders.
Let's start with paravalvular leakage, or PVL. This typically happens in the first year after implantation.
Right, while the body is still settling.
The artificial valve itself is opening and closing perfectly, but the seal around the outside border of it is failing. The CT scan looks for contrast-enhanced blood flowing around the outside of the sewing ring.
And in severe cases, the CT can spot what is known as a rocking valve.
A rocking valve. That sounds bad.
It is a condition called dehiscence. It is where the surgical sutures have actually torn through the patient's tissue, and the entire metal valve is literally rocking back and forth, ripping further away from the heart wall with every single beat.
That is a catastrophic structural failure.
It really is. But an even more insidious invader is prosthetic valve endocarditis, or PVE.
Which is an infection.
A severe bacterial infection. Microorganisms enter the bloodstream, sometimes from something as simple as a dental procedure, and attach to the foreign material of the valve.
Just from going to the dentist.
It happens. They form these dense clumps called vegetations. But the real danger isn't just the clumps. These bacteria actively secrete destructive enzymes that eat away and liquefy the surrounding heart muscle.
Okay, I have to play the skeptic on the diagnostic process for this, though.
Sure. What is on your mind?
The consensus document talks about utilizing molecular imaging for these infections, specifically an 18F FDG PECT scan, which uses radioactive sugar to find metabolically active infection hotspots. If a patient is already in the ICU, visibly sick with a blood infection, aren't we just throwing them into too many machines? Like, why do they need an echo and a PET scan and a CT scan just to find an infection?
If we connect this to the bigger picture of how surgeons plan their operations, you will see why this multimodality approach is completely necessary.
Okay.
Every machine answers a completely different piece of the puzzle. The echo is fantastic at seeing the real-time blood flow to show exactly how badly the valve is leaking.
But the shadow problem.
Exactly. Because of the acoustic shadow we discussed, the echo might completely miss a massive pocket of infection hiding behind the middle ring.
So then use the PET scan.
Right. The PT scan uses radioactive sugar to find the invisible chemical footprint of the bacteria. It proves that the tissue is actively infected and metabolizing that sugar, even if the structure looks completely normal.
And then the CT ties it all together.
Finally, yes, the CT scan provides the ultra-high-resolution structural map. CT can spot paravalvular abscesses,
What are those?
pockets of dead tissue, and pus deep in the heart muscle. It can also find mycotic aneurysms, which are places where the bacteria have eaten through the blood vessel wall, creating a weakened ballooning pouch ready to rupture.
Wow.
By combining all three, the surgeon knows exactly which microscopic pieces of the heart wall have been liquefied before they ever make an incision.
It is like having a sonar for the blood flow, a heat vision camera for the bacteria, and a structural blueprint all layered on top of each other.
That is a perfect way to describe it.
That level of detail is necessary for the acute emergencies. But the research also shifts focus to the silent, decades-long threats that specifically affect biological valves.
The slow-moving dangers.
Exactly. Structural valve deterioration, or SVD, is the irreversible wear and tear of that animal tissue. It usually takes 5 to 10 years to cause problems. But the imaging tech is now so advanced, doctors can see it coming years before the patient feels it.
Yeah, the sensitivity is incredible.
Using a specific radio tracer, 18F fluoride PET, they can detect active microcalcifications smaller than 50 micrometers.
50 micrometers.
We are talking about seeing individual specks of calcium forming on a valve leaflet before a standard CT scan can even register them.
And there's another silent threat discussed in the research that is currently a massive clinical headache for the medical community.
Oh.
It's called HALT, Hypoattenuated Leaflet Thickening.
HLT, what exactly is thickening?
It is this strange phenomenon where a thin layer of blood clot forms stealthily on the biological valve leaflets. On a CT scan, it shows up as a very specific meniscoid shape,
Meniscoid.
meaning it is thick at the base where the leaflet attaches to the frame and tapering off to be paper-thin at the tip.
The way I picture HLT is like a stealthy layer of winter ice forming on your car's windshield wiper. That makes a lot of sense.
For a long time, the wiper still moves. It sweeps back and forth, clears the window, and you don't really notice anything is wrong while you are driving.
The valve still functions perfectly fine on a macro level.
Right. But eventually, the ice buildup gets so heavy and rigid that the mechanical arm just jams. And biologically, if that clot buildup gets bad enough, it leads to REL-M, reduced leaflet motion. The biological leaflet just gets too heavy and stops opening all the way.
So what does this all mean, like, for the patient?
Well, what makes ATL such a controversial topic right now is how shockingly common it is.
Is it that prevalent?
In massive, low-risk clinical trials, like the Partner 3 and Evolute trials, researchers found that subclinical ATL was present in 20 to 31% of patients.
Wait, up to a third of patients?
Just 1 year after getting a transcatheter valve, nearly a third of patients have this strange thickening occurring, completely silently, with absolutely no symptoms.
So do doctors intervene? Do they treat it?
That is exactly the debate. The medical community is torn on whether this is a crisis or a harmless biological quirk.
Why not just treat everyone to be safe?
Because if you aggressively treat that 30% of patients by putting them all on heavy blood thinners, you're introducing massive bleeding risks for a condition that might never actually hurt them.
Oh, right. Blood thinners have their own severe side effects.
Exactly. Many patients with HLFV have perfectly normal pressure gradients on their echocardiograms for years. But if you do nothing, does that subclinical thickening inevitably lead to long-term structural failure? Or worse, a piece breaking off and causing a stroke 5 years down the line?
That is a terrifying unknown.
We don't fully have the answer yet, But CT is the only reliable tool capable of grading this thickening and tracking it over time across thousands of patients to finally solve that mystery.
Which brings us to the final piece of this. We have used the CT time machine to defeat the metal shadows. We have diagnosed the creeping vine of the Pannus scar tissue, mapped the exact borders of a bacterial abscess.
We've collected all the data.
Right. How does a surgeon actually use this massive amount of CT data in the operating room?
When a patient requires a redo operation, meaning their chest has already been opened in the past, the CT scan becomes the surgeon's absolute lifeline.
Because of the old scars.
Yes. Preoperative planning with these 3D models maps out the exact course of any old coronary bypass grafts so the surgeon doesn't accidentally sever them.
Makes sense.
But the most critical measurement the CT provides is the exact physical distance between the back of the sternum, the chest bone, and the right ventricle of the heart.
The mechanics of that second surgery are terrifying to think about. When a chest has been opened before, the healing process isn't clean.
Not at all.
The body creates dense, sticky scar tissue that can literally fuse the front of the beating heart directly to the back of the chest bone.
This raises an important question about the psychological reality of the operating room. Imagine a surgeon holding a bone saw, preparing to cut down the center of a patient's sternum for a second time.
It makes my stomach drop just thinking about it.
Because of that scar tissue fusion, they are flying entirely blind. If they run that saw just 1 millimeter too deep, they will slice directly into the right ventricle, causing a catastrophic, often fatal hemorrhage before the chest is even fully open.
So the CT scan completely changes the psychological approach to the operation.
Completely. It measures that exact clearance down to the millimeter. If the CT shows the heart is adhered too closely to the bone, the surgeon won't even pick up the saw.
They just stop the surgery.
It will completely change their surgical strategy. Perhaps opting for a transcatheter valve-in-valve procedure going in through the leg to avoid the chest altogether, the CT scan removes the blindfold.
And the hardware is still evolving.
Yeah.
The consensus document highlights emerging technology like photon counting detector CT.
Oh, that tech is incredible.
It is next-generation imaging that provides ultra-high spatial resolution and spectral-based reconstruction. It is so precise that it nearly eliminates the metallic glare altogether without needing all the heavy software scrubbing.
It is the equivalent of simply turning off that blinding stadium spotlight so you can just see the anatomy clearly.
We are moving past just looking at static anatomy. The frontier of cardiovascular imaging is about seeing the cellular metabolism, the physical forces, the blood flow, and the structural integrity of these artificial materials all in real time.
It is a whole new era of medicine.
We started this deep dive looking at the frustrating acoustic shadows of standard ultrasounds, and we traveled all the way to the time-freezing, metal-penetrating physics of 4D cardiac CT.
It is a long journey.
The sheer amount of data, physics, and biological detective work that goes into keeping just one artificial heart valve functioning is staggering. The next time you hear about a family member or a friend getting a heart valve replaced, you will know.
You will know exactly what goes into it.
You will know about the invisible, multidimensional technology shielding them, tracking every single beat, and catching clots, hidden infections, and microscopic calcium before they can cause a catastrophe.
I want to leave you with one final thought to mull over, though.
Lay it on me.
We talked about how 18F fluoride PET and photon counting CT can literally see individual molecules of calcium forming on artificial tissue right now. The microscopic images are already there, the data.
Right, the sub-50 micrometer specs.
Right, exactly. So how long until artificial intelligence is trained to read those millions of microscopic changes? How long until an algorithm can look at an invisible speck of calcium on a scan today and accurately predict the exact day a biological valve will fail, years before the patient ever even feels a flutter in their chest?
When the X-ray machine truly becomes a crystal ball, that is something to think about. Until next time.